You can turn it on. You're on now. You
Okay.
can put it in your pocket or
Super. Welcome to the Lefeber Winter Series on Aging. This is the 29th Lefeber Winter Series on Aging. That's pretty good. I think it was been named the Lefeber Winter Series for about 20 years because I started it before that. My name is Jim Goodwin. And let me just say a couple words. We normally have a slide on it, but we're in disarray this year. Pardon our disarray. The series is named for Dr. Edward Lefeber, who was an internal medicine doctor in Galveston, practiced at St. Mary's and had an active practice. And many patients saw him in Galveston. More recently, it's really named after Nancy Lefeber Hughes, who, as you all know, died tragically in a what was at the time a hit and run when she was out on her morning bicycle ride. And the impact of, if I hadn't already known, because I worked with Dr. Hughes when she was a resident in internal medicine, and actually tried to get her to do a fellowship in geriatrics because she was just so perfect. But further evidence of that was after she died, we all in geriatrics had to take care of some of her patients. And just the profound look of disappointment when they saw me was ongoing evidence of what a warm and caring physician she was. She had started out as a nurse, and I think that helped enormously in terms of empathy and understanding. A couple more things. This is virtual, so a lot of the audience is out there somewhere in space. And for those people who are, there's a chat feature on your computer or something, and that's going to be the way if you want to ask Dr. Bynum questions, because staff will read the questions to Dr. Bynum. So it's like you're out there and Dr. Bynum's out there somewhere, and the rest of us are here. So we're really honored to have Dr. Julie Bynum come to us today and talk. She's currently an endowed professor of internal medicine at University of Michigan, where she is in the Department of Geriatrics and Palliative Medicine. She grew up in Albany and then went to graduated from Union College undergraduate in Schenectady, summa cum laude, and then went to Johns Hopkins University School of Medicine, where she got an MD and an MPH, and moved on to Dartmouth-Hitchcock, where she did her internal medicine residency and also a chief residency in internal medicine. She went back to Hopkins for a geriatric fellowship, and then went back to Dartmouth to be a faculty member. Sometime at Dartmouth, she also took a couple years to do policy fellowships with the Center for Medicare and Medicaid Services. So her research, as you'll see, and her talk is very policy-oriented, sort of what can we do type questions, as opposed to, and so her career has been sort of studying what is medical care for the elderly, particularly in dementia in the U.S., and then what are interventions that might improve it. She's had impressive career of high visibility, high quality publications. She is funded by a large number of grants from the National Institute on Aging. She has a center grant called a CAPRA, something like a CAPRA, that is a big grant that is to promote population-based research in Alzheimer's patients. She is a co-investigator on several other center grants, including the Michigan Pepper Center, the Michigan Alzheimer's Center, and others. And then she has regular research grants. And she also finally is, must be a very impressive mentor, because she is the primary mentor on quite a few junior faculty at Michigan in their K grants, in their NIH supported career. So today she's going to be talking to us about the care delivery for Alzheimer's disease and dementia. So welcome, Dr. Bynum. And she's virtual. And welcome, Dr. Bynum.
Thank you. Thank you very much for that lovely introduction and a review of my life history. It feels like it's all gone by so quickly. Thank you for all of you who are there in person and virtually. As usual, I have a lot to say and not enough time, but you wouldn't want to stay longer to listen to everything. So I'm going to dive right in with this topic that I'm going to share with you today called Alzheimer's disease, dementia, and care delivery, triumphs and threats. Just because we're obligated to do, oh dear, I cannot get my slides to move forward. There we go. This is that list of grants, and mostly this is just to say I don't actually have any conflicts of interest with anything I'm going to say. These are all just mostly federal grants. So my goals for today are threefold. The first thing we're going to do is I want to help you understand something that happened historically around 2011. The U.S. passed legislation to create a national plan for Alzheimer's disease. And I want to help us all understand a little tour through history, why that came to be. And then we're going to go on and talk about some of the current triumphs in the field that really probably are a product of some of that legislation, and then articulate why we should be concerned about being able to really actualize on those triumphs. But first, I'm going to go in the clinical route and describe a case for you. This is kind of a lengthy case, and I'm just going to dive in. It means a lot to me personally, this particular case, and I think you'll understand why. And we'll do the case, and then we'll move on to these three goals. So we're going to start out talking about Mr. Frank, which is a pseudonym, but it suits him well for his demeanor. He is a gentleman that I saw at the Geriatric Medicine Primary Care Clinic here at University of Michigan. That's a picture of it. The context was his primary doc was on a leave for 6 months, and he hadn't been seen for over a year. So he was scheduled with me. I didn't know him for a 30-minute visit to sort of catch him up on whatever's been going on. So he comes into the office. This is in 2019. He's 86. He comes alone. He was actually widowed in 2017, which he talks about. He lives alone except for his dog in a single-family home. He's a retired office clerk in sort of an accounting area for Ford Motor Company. Around here where I live, I'm a short 40 minutes from Detroit. We see a lot of auto workers and retirees from the auto industry. He describes feeling well. He doesn't have any concerns. He walks his dog every day. He's really, it says, as an entirely negative, what we call a review of systems. I couldn't get him to say he had any problems at all. His past medical history is pretty remarkable. He's got a lot of vascular disease. He had coronary artery bypass surgery almost 20 years ago. He's had an artery to his brain, his carotid artery operated on. He has plugged arteries to his legs. He has an abdominal aortic aneurysm, which is a dilation of the aneurysm, which is very serious. His kidneys aren't working as well as they should, probably also from this vascular disease. He has high cholesterol, high blood pressure, and he also has some arthritis. And he's on these 4 medications, which are appropriate for the diseases that he has. On exam, he's actually a slender guy. He's 5'8". He's really alert and attentive. He speaks really well. His exam's unremarkable, and I didn't do any formal cognitive testing. Ordered a bunch of labs because he hadn't had any done in quite a while. What I found is his cholesterol and glucose were normal, but he'd developed an anemia. And in medical terms, it was called normocytic, which in his case turned out to be because he had not enough iron, and also he also was having problems with his kidneys, which was affecting his anemia. And his kidney function had gotten worse with that creatinine value going from 1.7 to 2.0. So a whole bunch of labs, additional labs were ordered, as well as an abdominal ultrasound. He was sent off to see gastroenterology and nephrology, which are the kidney doctors. But, you know, the very good staff in our clinic reached out to me because they noticed something really odd when trying to schedule. He insisted he had no knowledge about any referrals. So that triggered me to go back to the record and found in a tucked away in a corner of our electronic record, a mini mental status exam test, which is a screening test we do for cognitive impairment, done back in 2016, which was not normal. It was 24 out of 30. For his level of education, we would expect that to be a bit higher. So I actually start seeking out the social worker to help me coordinate a visit with a knowledgeable informant because I had some difficulty figuring out who the right person to contact was. Meanwhile, she was trying to contact me because her daughter had called, concerned about a large amount of funds, over $200,000 that had gone missing. And she was concerned that the house cleaner was stealing from him. Of course, from our perspective, we didn't know if there really was money stolen. We couldn't say who the actual person stealing was, would be. Was it the daughter or the house cleaner? We would have no knowledge. So we set out to do what we do in this situation from the clinic. We called the Adult Protective Services. We scheduled a follow-up with the patient, and actually the housekeeper attended the visit because we needed a knowledgeable informant to come with him. Given the circumstance, it was pretty sure that this was going to be a legal matter, so we actually initiated formal neuropsychiatric testing, which was actually miraculously able to get fairly quickly. At the same time, his daughter, who lives out of state, and it is his durable power of attorney, gets a lawyer, files a police report, gets the bank to do whatever it can do to limit access. There is a second daughter who's local, but there's been some Mr. Frank has been a bit challenging earlier, so there's some disconnection between the second daughter, although she is available if we need her. But on the drive home from his clinic visit with the GI doctors, he actually has a large upper gastrointestinal bleed. So now we know where that anemia is coming from. He gets admitted to the hospital and he has grade D esophagitis. What's going on the personal side? Well, another month later, we get a neuropsychiatric evaluation that says he actually has severe impairment in decisions with poor judgment. He's unable to write checks alone or do balances. And because of the concerns for his safety, for things like being able to get out of the house in a fire and being taken advantage of, they actually recommend 24-hour, 7-day-a-week supervision. Interestingly, his speech was totally fluent, and his mini mental status exam at this point is 22. So based on this, the lawyers assign him conservatorship to the daughter, which is the same as being a guardian in our state of Michigan. When I see him back in clinic, he has absolutely no insight into his decisional issues. He stays abreast of current and financial news, so that our social worker is working with his daughter to get him a supervisor arrangement. By this time, the cleaner's totally gone. In fact, the final police report comes out. There's not going to be any charges. They couldn't even find the house cleaner. She disappeared. And Mr. Frank told them that he probably gave them the money freely. And he probably was being taken advantage of. So they did not take that case any further. Unfortunately, not much further down the pike, Mr. Frank slips getting into the car and fractures both his shoulder and his hip. He goes to the hospital, he gets rehab, and after that rehab stay, they're able to get 24-hour caregivers into the home. He sort of accepts them into the home, which has been a problem. However, he really has some major behavioral challenges and conflict with the paid caregivers, sometimes even locking them out. They'll be on the phone talking to the daughter who's in DC from the driveway, just sort of watching from the driveway because he's locked them out. In addition, in this time period, one of the paid caregivers got him to buy her a car. Police were called, the car was returned the next day, and the dealer agreed to accept the car since they accepted a cash deposit and signed document with a person who was under conservatorship. My geriatric psychiatry colleagues tell me this is an all too common experience that they have come up pretty regularly. So over the next months, we actually develop what I call a stably unstable caregiving arrangement. He gets a local doctor. He actually lives 45 minutes away from where my clinic is, and the distance was too much. And he continues to refuse to move into assisted living. Thankfully, they have a fair bit of assets, so the family reserves an assisted living home room for him, actually keep it on hold for him during COVID, so they have someplace to take him, although he doesn't, it's pretty quiet during COVID. Now we're in 2021, the lawyer initiates a civil suit to recover $535,000 that the forensic accountant has discovered has been missing from his accounts, presumed stolen by the house cleaner and her family. The night that he moves into assisted living, because it finally got to the point where they had to do that and they had difficulty getting caregivers, he actually threatened suicide. He was hospitalized, and I got this page and call from the psychiatrist on the unit saying, "I don't understand. What's going on? He knows current events and he's calm. What's the issue?" told the story, sent the neuropsychologic testing and the history, and in fact, his mini mental status exam during the stay was 15 out of 30. So he has this ability to maintain his ability to converse and sort of know what's going on by watching TV and the news all day long, but really has very poor judgment and other cognitive skills. Go forward another couple of years, Mr. Frank passes away peacefully 2 days before the civil trial starts. The judge ruled against the housekeeper and awarded the family, the plaintiff, $1.6 million. The plaintiff's lawyer told me they don't expect to capture any of those damages. They just really didn't want this person to do this to someone else again. So usually when we do one of these cases, the question is the big medical mystery. What do they have? And that's not the case here. What Mr. Frank had was dementia. Dementia is an acquired clinical syndrome. You're not born with it, of loss of cognitive abilities, often memory loss, but not always. That's serious enough for you to really interfere with your daily life. There's one of the things I really want to make the point of is that dementia is a general term, and there's lots of different causes. In his case, it probably wasn't standard Alzheimer's disease, although we don't know. But the things like vascular dementia, Lewy body, Alzheimer's, the most common is actually mixed. So this plot on the right is how I was taught about dementia, that you have the early phase where there's some cognitive symptoms, loss of function, and then progression, ultimately leading to death. Over a period of something like 10 years, 5 to 10, or even 15 years. It's fairly unpredictable. So my question first is what did you find most striking about this case? I think there's many things, like how much money people could steal. How could he even survive to 86 with so much vascular disease? But for me, the most striking things was how helpless I was, how unable I was to provide any help to this family. The tools of medicine were not what they needed. And in fact, the legal system actually didn't help them either. So we're going to put that case in the back of our minds, its complexity and sort of the troubling things it raises. And we're going to do that little history lesson where we talked about in 2011, there was a National Alzheimer's Project Act enacted. And what happened out of that is one of the many things that happened out of it was a tremendous increase in the amount of NIH funding put toward the problem of dementia. But I think you could ask, why have a national plan for Alzheimer's disease? I mean, do we have a national plan for Parkinson's disease? No. So what's going on with that? So let's talk about that a bit. Back in 2011 is when the NIA diagnostic guidelines came out for Alzheimer's disease and Alzheimer's dementia. So this is the specific biologic mechanism of dementia caused by Alzheimer's disease, which is caused by the buildup of proteins in the brain called amyloid and tau. And so the idea was that we have these periods, what they've come out with now in 2011 is that there's the clinically observable period that was in my prior graphic, right? But then there's this long preclinical phase where these proteins are building up. And about this time, there were a whole bunch of clinical trials and interventions that all failed. So people were sort of realizing that the field needed to change and change dramatically with the ability to identify people much earlier before they're having symptoms so that we can address these proteins that are building up in the brain in hopes of finding treatment that will actually alter the course of the disease. Okay, so we have a disease that has no treatment, but of course there's a lot of diseases with no treatment. So what else is going on? So let's think about how many people are really affected by this disease. First of all, dementia is very age-related. So the likelihood of having it, the prevalence increases with age. And as we all know, we have an aging population. So the projected number of cases over the next decades is really expected to increase dramatically, as this figure on the right shows. But in addition to dementia, we have this condition called mild cognitive impairment, which is thought to be a precursor. Now, mild cognitive impairment is even more common, particularly at the older ages. So what that means is that if we put the two together, the number of people who have some level of cognitive impairment is expected to really, really escalate dramatically over the next 20 years. And this is a disease that we don't know how to treat, but can't sort of alter the course. So on top of that, research showed in a 2013 paper that the costs of dementia are on par with heart disease and cancer. People didn't really think of it that way before because they really paid attention to just the hospital costs. But if you count in all the long-term care costs, dementia costs as much as heart disease and cancer. So these numbers are in 2010 dollars. If you want to put that in today's dollars, you multiply that by 3. One of the interesting things, though, is the type of costs that we're dealing with in dementia are not the same. So, because of the need for supervision and safe housing, there's a great deal of what is called informal or unpaid caregiving. Spouses and families are really having to give a lot of care to keep people in the communities and keep them safe. For cancer and heart disease, we talk about the productivity loss from early mortality, which is really not an issue or very much smaller issue in dementia. There is younger onset disease, but the real loss to productivity here is all these informal caregivers who are having to reduce their work as members of the sandwich generation. So when you add in all the unpaid care costs, this disease actually costs tremendously more, another 60 or $100 billion more than heart disease or cancer. So what drives the policy? These costs drive the national agenda. So it's not only common and untreatable, it's very, very expensive for everyone. So the goal of the NAPA Act it still goes on, to improve the health outcomes of people with ADRD, which is their abbreviation for dementia of any cause, and reduce the financial burden of these conditions on those with these diseases, their families, and society. So when we're talking about reducing the burden of a disease in populations, we're often talking about public health kinds of approaches. We're talking about preventing people from becoming at risk, or taking people who are at risk because they have certain biomarkers and preventing them progressing to established disease. Once people have established disease, we're going to try to mitigate those effects, prevent hospitalizations, and help people live as well as they can with the disease. Currently, we're really up here in this far right piece of really doing the tertiary prevention or the treatment and management of people, even with the new drugs, which I'm going to talk about in a minute. So these figures are something that I used in a paper where I was trying to sort of articulate. At the time, there were no treatments for the disease that were disease modifying. There were some symptomatic drugs. People were pretty nihilistic, but I was trying to convey that there's actually a lot we can do, even despite not having a treatment, to improve the life and reduce the burden of on people across the full spectrum of the disease. And that's what this figure is really meant to convey. As I said, there were no treatments. But this brings us to this first triumph I wanted to talk about, the triumph of drug discovery. So what you're seeing here on the screen is the headers from 2 papers that were published in 2003, which is the advent of the disease-modifying therapies era for Alzheimer's disease. These are drugs that remove amyloid from the brain and have a clinical impact on people, a positive clinical impact. I will say there are many, many trials, lots of drugs that work this way that weren't successful, but these 2 drugs have shown success. I'm not going to continue to talk a lot about these drugs as how they're used in treated individuals. In fact, we're not really going to talk about that at all. I'm going to talk about it more on the population level. But let me give you some just nuts and bolts about this drug lecanemab, which has been approved by the FDA, and what this trial actually showed. So this was a clinical trial that was 18 months long. So it's only 1 year and 6 months long. That's the most we know. And the magnitude of the benefit is about the same we see for current drugs on the market, donepezil. The estimate is that it doesn't improve functioning. It actually just slows progression by about 4 or 5 months. Two of the tricks of this disease that gives us a little worry, though, is adverse effects are really common. And those 2 adverse effects that are called ARIA-E and ARIA-A are swelling and hemorrhages, microhemorrhages in the brain. And we don't know the long-term impact of those. But really, these drugs, one of the big concerns is they're really expensive. The drug itself is $26,500 a year, and the price tag for doing the treatment that has to go all around it, because there's monitoring and MRIs and diagnostic tests, is about $82,500 per year. And it's estimated there's about 1 million people eligible, which, if you do the math, is $82 billion in a year. So they're expensive. But this is really hopeful. This is great for the field. This is a triumph that we finally have a disease, a drug that can actually change the trajectory of the disease. So let's move back to this idea of populations and how we're going to reduce the burden of this disease. We'll get back to how these drugs might help. So one way to reduce the burden is to reduce the number of people who have the disease, of course. So let's look at this little diagram I have to explain how we do this. That's a funnel holding all the people living with dementia. And what goes in the top of the funnel are new cases. We call those incident cases. In medicines, the new cases. And the way we reduce the number of incident cases, actually people will die with this disease or they'll be cured. In this case, there is no cure for this disease. But what's really interesting in the current context, evidence is in the US and worldwide, the rate of new cases has actually declined. So the sort of percentage of people who are actually coming down with this disease are declining over time. So why is that? It's still under investigation, but we really think this has to do with improved education, so people have more sort of brain reserves as they reach older age, improved living conditions, and probably lower vascular risks as well. But despite the decline in the rate of incidence, we will still have a huge growth in the number of people with Alzheimer's disease. And that's because of the growth in the population, the wonderful growth in the population who are older adults, which this figure on the left shows. This is the world increase in the world population, percent of the world population who's over 65, which is a great victory of medicine and public health and education and economics in the world that we have this increase. But what does that do to our little figure? It just basically makes everything bigger. It makes the pool bigger. So even though we might be getting a slower incident rate, we're still having more cases. But what would drugs do to this? Lots of people have been modeling this over years. And, you know, if we had a drug that could actually, that treated the biologic Alzheimer's disease, those, you know, prevented those proteins for just building up in the brain, we could prevent the onset of dementia itself. Those people would never even go into the funnel. But even if we couldn't do that, if we had drugs that could just delay the onset, so they do something, they don't prevent it entirely, but they delay the onset because this disease comes on so late in life, probably many people would die before they actually transitioned into dementia, which would also lower the number of cases. But what do the current drugs do? The current treatments actually only slow progression among people who already have symptomatic disease. There are trials of people doing it in asymptomatic, but what does this mean? So this actually doesn't decrease the number of people. And one of my mentors, Peter Ravens, had said to me as I was sort of going over this with him, he said, Julie, you know, this might mean people live longer and actually increase the number of people with the disease, which is a little sobering. So, one of the things is, though, what's the threat here? It'd be great if these drugs really did help us delay the onset and all these other things, but the success of these new drugs as a population strategy is totally dependent on what's causing the dementia. It's totally dependent on whether it's the disease mechanism of Alzheimer's. And it turns out, from great work done at Rush, that in fact, most people have mixed pathologies, and about even among people in studies that they really thought in life have Alzheimer's disease, only about 65% of them had Alzheimer's disease at the pathology. So what's that mean? Even if we could give these drugs to everyone and eradicate the biologic mechanism of Alzheimer's disease, we're still going to have a lot of people living with dementia. So that's a problem about who's going to get better, who's really going to benefit from these drugs. There's a second problem in that we've been talking about amyloid and tau, and all of the literature that helps us understand how these operate are from studies of people of Western European ancestry. So we don't have great underlying scientific data about diverse populations in these proteins. And moreover, the clinical trials had very poor representation, particularly of Black populations. The lecanemab did better with Asian populations, but you can see from this slide, we don't know a lot about the other groups. So here's my threat for this. Who's going to be left out? Who's going to be left out of these great triumphs of these drugs? Certainly anybody who has a cause of dementia that's not Alzheimer's type. And there are certain subgroups of people who are at greater likelihood of not having that, having Alzheimer's. So people who are at higher stroke risk, which is related to race, for example, or people with younger onset, which is associated with having frontotemporal disease. But the thing I'm going to talk about a little bit more here is, what about the socioeconomics? Who could afford these costs that aren't covered by insurance? And importantly, who has the knowledge and access to seek out the specialty treatment centers that are going to be required for delivering these treatments. So we're really going to focus on this last bullet, knowledge and access to seek out treatments. So one of the things on this pathway to get these treatments is you have to have your disease diagnosed. And what we know from the literature is that about 62% of people who have this disease in the community are not yet diagnosed. It's very high. And that the people who do get diagnosed often have a late diagnosis, which are often there's often disparities related to who has has more late diagnosis. And of course, to be eligible for these drugs, you need to be in the early phases of this disease. So diagnosis is hard. So what's going on here? Why aren't people getting diagnosis? This is a great model from the National Academy of Medicine that sort of explains the parts to the left, or what happens before the person comes in. They have to identify that they have a health problem. They have to engage with the healthcare system. Then the blue is everything that happens when you're having that patient-doctor interaction and all the tests. And then at the right is once the doctor knows the diagnosis, they have to communicate it, and there's treatments and outcomes. The literature suggests that there are problems on this pathway for getting a diagnosis of dementia at all sorts of levels. There's a lot of stigma of this disease, and some groups really believe this is part of normal aging, so they don't come forward. We don't have a lot of availability of Alzheimer's expertise, which we'll talk about more. Even the tests we use can have biases in them, and physicians themselves report feeling inexperienced and unsure of making this diagnosis. So for me, this is a particularly vexing issue, because what I do in my research is I use data that comes out of these healthcare interactions that generates a bill or a diagnosis in an electronic health record. So it's really important. I'm not going to say we shouldn't use these data. Obviously, it's the work that I do. But we need to think really carefully about, again, who's left out, who we're missing, and where are these data going to be more or less accurate. So as a little aside for the researchers in the room, I'll just share that one of the projects we did fairly recently is to test and develop new algorithms to identify people in claims. The old algorithms were based on healthcare delivery in the late 1990s, which certainly is different today. And then we compared it and validated it against the Health and Retirement Study, which is a sort of reference standard. And then we did it again, validated it again against the Rush studies, which is a more clinical gold standard. For people who are actually interested in the details of this, I gave grand rounds on the details of these two papers, and it's on the website for the Impact Laboratory at their knowledge repository. So when we apply this data, this is a map that shows you the proportion of people in different areas. These are called hospital referral regions who have in Medicare who have a diagnosis of Alzheimer's disease. So this isn't who has the disease, it is who has the diagnosis of the disease. And what you see is it's not the same everywhere. It ranges from 4% to 12.6%. So why might that be? Well, there could be a lot of reasons. But one, I told you at the beginning, we're sort of learning some epidemiology logic that this is a very age-related disease. So if where you live is very much an older population, you're expected to have more dementia in your population. And we would call that warranted variation. We expect that, and that's not something that we're worried we're doing something incorrectly in medicine. But another thing that I'm concerned about is maybe we're not looking hard enough in some populations. And that would be what I'd call unwarranted variation. We're going to talk about that a little bit more. Because when we look at this, I can't tell you if 12.6 is too high or if 4.0 is too low. I don't know if this is over or under diagnosis. So we did another study where we tried to get at this a little bit. We did the same thing at the state level with figuring out who's clinically diagnosed in Medicare claims. But then we tried to calculate using population information what the expected proportion would be based on the age and sex of the population. And you look at this map, and this is kind of funny, right? Green means the rates are much higher than we expect, and red means we're much lower. And these seem to have some correlation with areas of the country where there's a higher proportion of Black individuals. Well, that's because this is an inadequate risk adjustment. At this point in time, we didn't have race-based expected epidemiology numbers. So we expected, our interpretation of this is that our adjustment was inadequate. Our expected numbers were inadequate because we weren't taking into account for race. So some of the newest work I'm doing, and I'm going to share with you a little bit for here, is where we're doing that previous study, but in a much more sophisticated way. So the map at the left is updated with the most recent algorithm, and so really the colors haven't changed very much. But what we've done is come up with using population data and all sorts of other manipulations to come up with a much better expected number. And we calculate what we're calling a diagnostic intensity. What's the observed to expected diagnostic intensity once we take out the differences in diabetes, the differences in age, the differences in race, and all those other things that are contributing to the different rates? And this is actually actively under review, so I have this terrible thing across the front of it. But what this map shows you is red is very high intensity, blue is low, and it doesn't look like the map on the left. So it's not lining up with where we're seeing high rates of diagnosis and low. So what this tells us, we think there's something really going on here. We're on to something. Overarching and overall, the main outcome from finding from the study is that there are twofold differences in whether or not you get a diagnosis based on where you live across the United States. And it doesn't matter what your age is or your race. It's a twofold difference based on place. Well, one of the things that might be driving that is that you don't have access to a dementia specialist. Well, I got to tell you, this is kind of tricky, right? There's no specialty certification that labels somebody a dementia specialist. So how would you know, right? Traditionally, neurologists make the diagnosis. Psychiatrists manage a lot of the really tough behavioral disturbances. And geriatric medicine docs often are managing the later disease, particularly people who are in assisted living or nursing homes. So again, another old paper, we were actually studying pharmaceutical use in people with newly diagnosed dementia. And we stumbled on this interesting thing. We were interested in what doctors people were seeing right at the time they were diagnosed. And we came on this, that 60% of the people with a new diagnosis in Medicare claims didn't see a psychiatrist, neurologist, or geriatrician in the 4 months around that new diagnosis, which means that 60% of these cases were being diagnosed most likely in primary care. I don't know if that's surprising to you or not. I think the way primary care works, it's actually not terribly surprising. I think there's some important things to consider what that means as we looked at the whole population. I think we have this really great idealized, I should say, have this idealized idea of what primary care should do for people. It really serves as a hub and helps people where coordination happens. But if you think about a person who has cognitive impairment or dementia, who can't carry their own information from all these doctors back to the primary care, this could be really, really tricky as a primary care doctor to try to help a patient manage this. On top of this, if you're trying to manage the small percent of your population that you see who have dementia, you're dealing with a really complex healthcare system. This is a slide that has super busy on what I consider it's intentionally busy, the dementia care system or the older adult care system. For many people and doctors, you're dealing with a clinic and a hospital and people living in the community, looking at that top left. But for people who are older adults with dementia, they're living in assisted living, nursing home, which means you're coordinating with these different settings. They're also getting lots of other care. They're very likely getting community services, and how do you access them? And then there's the payment, which is really confusing across all the different settings for the patients and the family. So you can imagine it might be really helpful if you're taking care of somebody with dementia, if you have some expertise in dementia to help them navigate all that's involved. So that's what this next big triumph is. This is a new payment model from Medicare that's helping us pay for all the other stuff around the doctor care, the navigation, the interdisciplinary team, the support lines, the respite services. It's a way to pay for all that other care that historically has not had a funding mechanism. So this is really exciting for the care and many, many years in the making. It allows us to start addressing all these other red boxes that I'm showing on this slide, which it just skipped over. But the threat here, I'm going to just tell you right now, is the concern for how many doctors, I'm just going to focus on doctors at the moment, that really do have dementia expertise. We can choose them just based on their specialty, or we can do it as the concentration of their panel, doctors who really focus their panel on older adults. And these are the numbers. This is also preliminary. I'm actually already revised this, and we're going to be submitting this for publication. But you find if you just send somebody to a neurologist, it's only about 40% of them concentrate their care on people who have dementia, and only about 25% their Medicare population on dementia. And if you're lucky enough to get to geriatric psychiatry or geriatric medicine, they're going to have a lot of experience. But look at the numbers. There's very few. 132 geriatric psychiatrists. Oh my goodness, bless them. If we allow family medicine and internists who have a lot of experience, high concentration of these patients in their panel, there's actually more of them than there are of the neurologists and psychiatrists in the United States. Geographically, this is what it means. These are actually counts, the number of doctors in any given area. These are not number per population. And you can see large swaths of the United States with 0 or 1 of these specialists. So the threat on the payment model is we really don't have the health systems in place, the expertise in place. So there's a couple slides here I'm going to just sort of go over quickly to say, if you wanted to do this in your model, in your health system, what would you really want to be thinking about? I'd want to be thinking about where those specialists are. This is Michigan. It looks almost worse than the rest of the United States. Maybe it's just close up. We just don't have large parts of the state, I'm not even showing you the Upper Peninsula, just don't have these providers. The other thing I'd want to know is in my health system, if I do have the providers, where can I sit this facility? Because it turns out that if you're in a certain geographic area, not every hospital is the same, right? Certain hospitals specialize in certain things. So in our area, what that means is if you look at the hospital, this is just my hospital referral region where I'm sitting in just north of Ann Arbor. Hospitals 3 and 8, they're both in Ann Arbor. One is the tertiary care hospital, and the other is what we'll put in quotes, community hospital. It's actually a very large hospital. You can see they have the same number of Medicare admits, but St. Joseph's, 20% of those Medicare admits are people with dementia, and only 12% at Ann Arbor. So they're sort of managing different sets of the population. Okay, we're going to just briefly return to my case. Poor Mr. Frank and his family and this notion of protection from exploitation. This is a study that I did with Lauren Nicholas, really her brainchild, and Joanne Shu, who is at the Fed. Lauren Nicholas is an economist, and Ken Langa and I, where we took, what this graphic is showing is that we have the vertical line is when you get diagnosed. And if you're above the line, it means you're having more trouble with credit problems. So being late on payments and getting in trouble with the credit companies. And you can see once you have a diagnosis, there's a lot more of that when you have dementia. But we also show that you start having those problems 2 years before the diagnosis is even made. And in fact, you might think this is sort of a wealthy problem, like people who have money getting scammed or whatever. But in fact, the relationship is even stronger in low-income areas. And one of my takeaways is that maybe we shouldn't just be asking people, do you manage your own finances? Do you do your own checkbook? But also be asking, are you having trouble with late payments? Because that might not just be an indicator of low income, but it could also be an indicator of having cognitive issues. So I hope I've conveyed to you in rapid speed, which is probably overwhelming, the incredible complexity of this disease. This is a slide again from that paper that's in Health Affairs, where I showed, all the different angles of health policy that can be used to leverage and reduce the burden of this disease. It can be overwhelming, but I'll tell you, this is what I love about working in this space. There is so much to be done. All of us have so much to add. This is my last slide. I think just to summarize, we have these fantastic breakthroughs in the field, and we're sort of left with what do we still need to do to maximize our opportunities to really benefit from the drugs and the technologies and the new delivery models. I think we really need to be thinking about how we ensure these benefits accrue to the people who have the right biology and to an equitable distribution across people. And that even with an Alzheimer's treatment, we still have people living with this disease. So how are we going to staff and improve our delivery system? So I'm going to stop there with gratitude for your patience and listening, and gratitude to my team. I have a staff that's in the middle there, my CAPRA, Center to Accelerate Population Research and Alzheimer's collaborators, as well as my Impact Collaboratory collaborators funding. And then I love Dr. Goodwin's note of my mentees. They really serve as inspiration, and I'm delighted to have them as part of my my work. So I will stop there and take any questions.
Thank you very much. Do I need that other one that you have so that I can talk to the people? No. Okay. So we have plenty of time for questions for the audience here. And as I said at the beginning, for people online, they can use the chat thing, and Stephanie will read the questions. Yes, Dr. Morrow. You push it, I think.
All right, I'll learn. Thanks, Dr. Bynum. That was fascinating and depressing, and I was glad to hear your triumphs through it all. I was trying to come along with you on the triumph and not be kind of pulled down. But
Sorry.
No. I appreciate the good data. I was struck by the process of diagnosis and the big blue circle in the middle, and then how you sort of had all those kind of weak points and threats along the way. And this is just sort of a big picture question of, what you see at the NIH or other funding bodies in this area, are you seeing us hitting across that spectrum? I know you talked about, we're really only working on that kind of treatment end of things, but kind of just now, 2024, where are we at on our funding priorities, and do you feel like any of the pathway is a particular weakness or a particular gap in our focus? Thank you.
Yeah, thank you for that question. Some people who listen to this talk feel like it's a cry for geriatrics in the field and championing the need for people who do this field. But I agree with you. I think it's sobering. That we have so many great things happening, but we have some really important things standing in our way to actually have these things help people, which is our main goal. You ask about barriers for funding. I think there's a fair bit, certainly Alzheimer's funding for research is great, and much of what's in that figure is not biologic funding that we need. It's really the social science and care delivery side. I think there's a lot of work being done on stigma and special, ethnic and racial differences and use of the healthcare system and what the barriers to that might be. I don't think, personally, that there's enough done about, and maybe it's because it's not science, of preparing the workforce, the physician workforce, or any of the other workforce, to be able to up their game and be ready for managing this population. I do think on that far right side, the communication part of disclosing a diagnosis, there is some work there. But to my mind, the biggest gap is perhaps the implementation research or the workforce development to make us all ready to manage. And that may be in the sort of ACGME, the training of physicians realm, more than the NIH realm. Because, you can't, any doctor who comes out of any training can identify hypertension, elevated blood pressure. And it's everywhere, right? You go to the eye doctor and they're taking your blood pressure because it's just an expectation. I think any person, any physician, and actually nurse, or, I'm using physician as shorthand, who takes care of older adults and for any reason should be on the lookout for this disease. Because you know what? You're going to prescribe a medicine to somebody who's cognitively impaired and don't give them any wherewithal to support that decision, they're not going to be able to implement that plan. So I wish we treated this more like something that every single doctor needs to know. Probably not the answer you were looking for, but it is what's been on my mind and why I present the data as I do. I'm trying to use data to motivate change, and I think that's the change I hope to see.
Thank you so much.
Thank you. Questions from the audience? Yes, ma'am. This is tricky. You got to hold the thing down so that you see a green light.
It was a very nice talk, very interesting.
You see a red light.
There we
You
go.
go.
Very nice
Now
talk,
you
very
see a green
interesting.
light.
I was just confused, though, by this number, this $82,000 out of a $26,000 drug. So where is all that money coming from? And wouldn't that 50,000 difference be something we should aiming to reduce? Maybe the cost of the MRI, the PET scan, whatever?
Right. Well, I think we should reduce the cost of all of it. So, right. So the cost of the drug alone is only one piece. So if you count in having to have the diagnostic MRI or the biomarkers, the drug, there's an added cost of having it infused. So the cost of infusions. Because of the high rate of adverse events, there also is required repeated imaging and other follow-up. And so that's where the costs are piling up, is that it's not just one and done, give a drug and walk away, sort of, we mostly do that with osteoporosis these days. That it actually requires quite a bit of high-tech monitoring, which is very expensive. Yeah.
Yes, sir. Once again, you got to see the green light.
Push the button. Yeah, there you go. Thank you.
There you go.
Pediatrics has a program where every child that comes in for Medicaid evaluation gets a developmental assessment. So you find out, okay, every child gets this automatically. You find out, okay, how are they doing? Are they developmentally delayed? Are they having trouble? They also get a hearing test. And a couple things I'm thinking is there a simple test that can be done in a general office that could be tested out to see, you automatically do it. Your nurse or whoever is doing the screening, they do the height, the weight, the blood pressure, the neurological screening. I mean, you're going to find a lot of abnormality out there, but at least it's a warning to the generalist who's seeing most of these patients that something's going on.
Great. Yeah, it's a great question. If only, for diabetes, there's a blood test, right? Oh, I can just do a blood test again. It's just not that straightforward. Dementia is a syndrome, not a clinical, it's a whole compendium of things. None of the tests are terribly accurate. So in fact, the guidelines, the U.S. Preventive Task Force guidelines actually do not advocate screening for dementia because we don't have a clear path for treatment or management once screened. You screen for things you can do something about. Now that might change with the advent of the new drugs, but there's a second component here. I think most pediatricians would know or could access somebody who could do something about the hearing. I think even developmentally, you kind of have the system and can figure out something to do. I think that's not the case. Even if you knew what to do, you can't, as a physician, you wouldn't necessarily be able to access the specialists because there aren't enough of them. In addition, there is a clinical trial of screening. So there's the physician side, right? There's lack of confidence, lack of specialist support and others around to provide the care once it's identified. There's actually a randomized trial of screening. And what they found was they offered patients to be followed up. They told them that their test was abnormal, and lots of people didn't want to know. So it's a little bit, with children and slow development, the parents want to know and they want to do something about it. We're not in that place when it comes to cognitive impairment. Many people will decline to be evaluated, decline to be labeled. And I think many of us as family members, we probably overreact to somebody who gets labeled and treat them differently based on that label if we're really honest with ourselves. So I think there's some reason for that. So yes, wish there was something that said, yep, this is what we have in front of us. But it's just complex and there's preferences and so much involved that make this more challenging, I think, than things where we have straightforward treatments and diagnosis for.
Any other questions? Well, if not, thank you very much, Dr. Bynum, for a wonderful presentation.
Thank you. Thank you for having me.
And there's food out there, I think.
I'm going to
No.
click off. Thank you very much. Bye-bye.
Thank you.